Hi, this is Dr. Bhargava. In this video, I have several interesting teaching cases to share with you. Let's start with our first patient. Here we are looking at multiple images from an MR of the abdomen. And the images on the top are contrast enhanced images, so pre-contrast arterial and portal venous phase. Images on the bottom left are in and out of phase images, and images on the bottom right are T2 and T2 fat saturated images. So here the interesting finding is that we see two different kinds of renal cysts. Let's start with this one here in the right kidney. This is T1 bright and does not show any enhancement. This stays T1 bright from in to out of phase images and stays low signal on T2 weighted images and fat saturated T2 weighted images. So putting everything together, this is a hemorrhagic or proteinaceous cyst, and so this will be a Bosniak 2. The second one is better seen here on the T2 weighted images, so we'll start there. It's T2 bright. And then on T2 fat sat, it's bright. On T1 weighted images, it's dark, and it does not show any enhancement. So this is a simple cyst. So this will be a Bosniak 1. So two different kinds of cysts, Bosniak 1 and Bosniak 2, seen in the right kidney. This is our next patient, and this is a good example of how correlation of chest x-ray findings with the CT helps us understand the pathology better and become a better reader of chest x-ray. So let's start with the chest x-ray first. There is a ill-defined opacity that involves the right hemithorax, the mid to lower lung zones. The claustrophrenic angle is not clearly visualized. There is some obliteration of the right hemidiaphragm. The left side looks clear. On the CT, we find that there are loculated effusions. The pleura is thickened and shows enhancement, and there are foci of air. And so all of these signs suggest that there is underlying infection of this fluid in the pleural space. So that will be, the diagnosis will be empyema. This is our next patient. We have a single image from a barium study, and patient has swallowed the barium, and we see it in the distal esophagus, GE junction, and going down into further distally into the stomach. The interesting finding here is that this is the fundus and the air fluid level in the fundus, and right here is the gastric lap band. Now the gastric lap band is supposed to be up here in this location, and it has slipped and moved more inferiorly. And so this patient has a displaced gastric lap band. And so when this happens, they don't feel satiety after eating a small meal because the band has displaced, and because of that, they start gaining weight again. Here's our next patient, an older woman who presented with pelvic pain, and on their MRI, we are looking at T2 weighted images in all three planes. Then at the bottom, we have a T1 weighted sagittal image and a T1 post-contrast sagittal image. So let's start with T2 weighted images. There are foci of T2 hyperintensity of variable degrees with some fluid level also seen right there. So there are secretions in the endometrial cavity. They are not able to get out through the cervix into the vagina. The vagina here has been distended with contrast. And then these secretions are proteinaceous because they are bright on T1 weighted image, and there is no tumor there because there is no enhancement. And so these findings are characteristic of cervical stenosis. This is seen in older women. The cervix atrophies and the cervical canal is narrowed, so the secretions from the uterus are not able to flow down into the vagina, and so they keep accumulating and distending the endometrial cavity. Here's our next patient. We find that on these two images, the axial and the coronal image from the CT of the chest shown in lung windows, there are consolidative and ground glass-like opacities peripherally in both lungs, also seen here and here. And this finding is characteristic of atypical or viral pneumonias. We saw this a lot during the COVID pandemic as well. This is our next patient. Here again, we are looking at the pelvis, and we have T2 weighted images in all three planes, starting with the sagittal. This is the enlarged ovary on the left side right there, and this enlarged ovary has predominantly low T2 signal. And here I'm showing you uterus, and that the uterus is separate from this enlarged ovary because there are two pathologies that are T2 hypointense. One that is more frequently seen, which is uterine fibroid, and they could be exophytic. They could arise from tissues outside the uterus, such as the round ligament. And the second pathology that is T2 low signal is an ovarian fibroma. And so when you see something mass like T2 dark, think about fibroid. And when you establish that this is separate from the uterus and it is arising from the ovary, the diagnosis would be an ovarian fibroma. Here's our next patient, and here I'm showing you the right kidney. The left kidney is absent. So the left kidney can be absent from congenital agenesis, or more frequently, the left kidney or a kidney can be absent from prior nephrectomy. And so how to differentiate between the two? So when the kidney has been removed, you would find post-surgical changes, clips, stuff like that. And then you would find that the origin of the renal artery is preserved and it has been clipped right there at the near the origin, but you will find the origin. But here, since the origin is not seen and there are no post-surgical changes in the left renal fossa, this is not a case of prior left nephrectomy. This is a case of renal agenesis. Here's our next patient, and we're looking at MRI of the pelvis. So again, T2 weighted images in small field of view in all three planes, followed by a T1 weighted image and a ADC image. So they have a cyst in the pelvis, which is seen right here. It's T2 bright. It is related to the urethra. This is the urethra right below the urinary bladder, and this is the appearance of the cyst on the axial image, and here's the appearance on the coronal image. And so this is in relation to the urethra, so it's a cyst arising from the paraurethral or Skene's gland cyst. And when there is enhancement and restricted diffusion, we suspect that there may be some superimposed infection. So here we see low signal on ADC, and so it may be infected. This is our next patient, and this finding is not very commonly seen. Here we have a moderate to large sized left-sided inguinal hernia, and that hernia contains this thick-walled fluid. And on the sagittal image, we find that it's the urinary bladder that has herniated into the left scrotum. As a result of that, the UVJ has also been dragged along with the bladder, and that has led to obstruction to the left ureter, and we see upstream left-sided hydronephrosis. And so this is a acute situation that has arisen because of the herniation of the urinary bladder into the left scrotum. All right, so now we are looking at a single axial image from the CT of the abdomen and pelvis, and I want to draw your attention to these lines. You see these hypodense lines? These lines are artifacts. What are these an artifact from? So looking at the scout image, we found that they were wearing a jacket with a zipper. They have opened the zipper and they're trying to move it out of the field of view, but still it has led to these artifacts on the CT image. So always be on a lookout for artifacts and think about what could have caused this artifact. Here's our next patient. We'll start with the barium study. We find that they have a stent in the esophagus. They've swallowed the barium. Some of it has gone into the stomach. It could be water-soluble contrast as well. We see that there is a percutaneous gastrostomy catheter in place, and we find that some of it is extravasating from the right side into the right hemithorax and the right pleural space. And so the most common indication of putting in a esophageal stent is esophageal cancer. And we find that on these CT images, there is some surrounding thickening. The cancer is not very well visualized, but we see these foci of air extending from the right side of the stent into the right hemithorax. That's the place where the contrast has been leaking from. So there is a tumor that has eroded into the surrounding soft tissues, and we see the extravasation of contrast through this uncovered stent. And so this stent is made out of metal, and it's a scaffold, and it does not it's an uncovered stent, meaning that the metallic scaffold has holes where if there is a track like this, or like I showed you here, contrast can leak from the lumen outside. And so this is a perforated esophageal tumor. This is our next patient. They presented with shortness of breath. Here on the single frontal view of the chest, we find that the cardiac silhouette is enlarged. There is perihilar vascular congestion, so they probably have congestive cardiac failure. Again, a good correlation with their CT. We find that the left ventricle is dilated. We find that there is interlobular septal thickening, suggesting pulmonary edema. And we also find that there are small bilateral pleural effusions, consistent again with congestive cardiac failure. This is our next patient. They presented with an abdominal swelling, and a few days before the swelling appeared, they had a procedure where a VP shunt, ventriculoperitoneal shunt, was placed, and we can see part of the shunt catheter here on this coronal image from their CT of the abdomen and pelvis, also on the sagittal image. And then we find that it coils in the anterior abdominal wall subcutaneous space right there and here without ever entering into the intraperitoneal compartment. And since it's draining CSF from the brain, that CSF has accumulated, and this finding is called a CSF pseudocyst. And this means that the catheter is misplaced, and they have to revise the catheter and make sure that the tip is in the intraperitoneal compartment and is not ending in the anterior abdominal wall subcutaneous space, as we see here. So another artifact, these are two axial CT images from the same patient at two different time points. Look at the resolution of the images. So you'll find that the image on the left is more uniform, better looking. The image on the right is pixely and not very well looking. And so what has happened here? So the number of X-rays are less here compared to the other side. And what determines the number of X-rays? It's the tube current. So I went back and I looked at the image annotations, and we found that the image on the left, when it was acquired, the tube current was 305 milliamperes, and the image on the right, when this CT was acquired, they received an X-ray with a current of 137 milliamperes. So current determines the number of X-rays. The more number of X-rays, the better is the better looking is the image, but at the same time there is more radiation exposure to the patient. When you reduce the current, you reduce the number of X-rays, and the images start to appear pixely. That's like the basic of CT imaging. Here is our next patient, and the interesting finding here is that they have this large right-sided abdominal wall hernia containing a part of the stomach and small bowel loops, which we also see here on this coronal image. And the stomach is distended and not emptying. This is the part of the distal stomach and the proximal duodenum that is trying to go back into the intraperitoneal or the intra-abdominal cavity, and there is pressure here from the distended stomach leading to gastric outlet obstruction. So there is obstruction at the site of the hernia from the mass effect of the stomach onto the proximal duodenum. This is our next patient, and we have axial, coronal, and the sagittal images. This is again showing a finding that is frequently called incorrectly, especially by new trainees. And that finding is seen right here in the IVC, where in the portal venous phase, we find that the IVC is hypodense and it's not opacified at that level. And superior to that, we see the blood flow coming from the kidneys, which is excreting the IV contrast into the venous blood from both sides, opacifying the IVC. And so I've seen residents report this right here as a filling defect, also right here, and calling it a deep vein thrombosis. And so remember that this is just a mixing artifact and not a deep vein thrombosis. Here's our next patient, and this finding is very interesting. They presented with abdominal pain. We acquired a CT that shows a large stone that is in the neck of the gallbladder. We see intrahepatic biliary ductal dilatation as well. On the MR images, we find that that's the stone that is stuck in the gallbladder, and in such a way that it is having mass effect on the distal extrahepatic CBD, leading to intrahepatic biliary ductal dilatation. The stone is also seen here, and that pathology is called Mirizi syndrome, where there is a stone stuck in either the gallbladder neck or the cystic duct in such a way that it's causing mass effect on the extrahepatic CBD, leading to biliary ductal dilatation and jaundice. Here are two more images from their MRCP sequences showing the extrahepatic CBD continuing more distally as normal, and here's a composite image showing the part where there is mass effect on this extrahepatic CBD, leading to intrahepatic biliary ductal dilatation. All right, another chest x-ray, and this device here in the left chest wall is not a cardiac device, a pacemaker or a defibrillator. If you look at the leads here, they're going up into the neck, and this is a vagal nerve stimulator. It's important to know what devices are commonly used and what are the terms used to describe them on a chest x-ray. Here's our next patient. They had hematuria, and on this CT of the abdomen and pelvis, which was acquired without contrast, on this axial image we find this hyperdensity in the bladder. This is also seen right there and right here. So there's a clot inside the urinary bladder, and this clot is in the inferior aspect, and the urinary bladder, the rest of it is distended. There is some non-dependent air, and the other interesting thing is that they're tried to place a Foley into the bladder, and the Foley is ending only inside the hematoma. And the Foley, if it were here, it would have been draining the urinary bladder, but instead the Foley is here in the hematoma, so it's counterproductive because it's obstructing the drainage of urine, and because of that there is extensive distension of the urinary bladder. So this needs to be removed, and another Foley catheter has to be placed correctly so that it drains the urinary bladder and not stays in the hematoma. This is our next patient. We have two images. One is the coronal T2 weighted image, and then we have on the right an MRCP image. The coronal T2 weighted image shows these multiple gallstones. These are seen as filling defects inside the gallbladder, and here is the extrahepatic CBD. And as we trace it, we find that at the level of the ampulla, there is a stone that is stuck. It usually has that kind of a morphology, or a convex surface that is towards the CBD, and it is better seen right here. It's also called shouldering. Here's the stone that is obstructing the distal CBD. So look for it whenever there is a suspicion of choledocholithiasis. This stone would look similar to other stones that are already present in the gallbladder. Okay, incidental interesting finding on the CT of the abdomen and pelvis in the region of the scrotum. We see these tortuous vessels, also seen here on the coronal image and also in the sagittal image. This is characteristic appearance of varicocele on CT. Thank you for watching.